Today we are so happy to have from Rego Health Blair Grant, their clinical transformation consultant, and Carl Barton, their executive healthcare consultant, here with us today. Just a little reminder for our CMEs, if you could please um, have your username recognizable. First and last name is usually best, especially if you are using a phone number to dial in. If you could just DM me or chat me that, hey, this is so and so, that's super helpful too. Without further ado, I will hand it over to Carl and Blair. Mahalo for being with us today.
Yeah, thank you very, very much, everyone, for having us. We're excited to talk about a team-based care project that we did here in Hawaii. And so I will share my screen and we will get into that. While I'm sharing my screen, I will share my stress management. The predominant thing I do is surf. And I had a great weekend for managing my stress because there was some fun waves up on the North Shore. So yeah. But anyway, as Summer mentioned, and thank you for the introduction, I'm Carl Barton with Ergo Health, Executive Health Care Consultant. And I just turn it over to you for a second, Blair, just so everyone hears your voice, since you'll be on here later.
Yeah, sure. I'm Blair Grant. I'm the clinical transformation consultant here at the Ergo Health. My background is primarily nursing and being a nurse practitioner as well.
And I'm going to check really quick. Can everyone see this screen and that flashing that I'm doing? Okay. I've gotten 5 to 10 minutes into a presentation and realized that no one can see my screen. So I figured good to check up front. Little bit of background. Blair and I met each other around the Ornish program, right? I was in charge of bringing the Ornish program out here, and Blair was the first nurse case manager in Hawaii for the Ornish program. So those of you that may have had any experience with the Ornish program, you know that there's a big stress management and group support component of that. So I think good background information to have that really, I think, helps guide a lot of what we do, that experience. So with that, talk about the objectives today. We're going to review a care team that was deployed at 2 primary care practices with 4 PCPs, small private practices here in Hawaii. We're going to discuss how the team functioned as a seamless integrated part of the primary care practice and delve into an understanding of how the team supported patients with chronic diseases to navigate life stressors and crises, and how that support led patients to be more engaged in their care and move towards that side of the spectrum of self-management of their chronic conditions. Here. When we initiated this project, the focus was really cardiometabolic chronic disease management. And there was a vision there of providing whole person care, where the team would really support the person as opposed to being too focused on the chronic disease. One of the things that we really wanted to put into play here was expanding the practice's capabilities to address both clinical and non-clinical drivers of health. And we know with a huge shift towards, the importance of social determinants of health, both identifying and addressing those things, that there's, a lot of work to be done to improve those capabilities and practices. So to do this, we used a small care team that included a health coach. And this team member proved instrumental in supporting patients through life stressors and crises. And we can see here from the slide that lands squarely in the American Medical Association behavioral health definition. And the team supported, these things through a probably higher touch model than you would typically have. The support was offered through telehealth and telephonic, and patients typically took the telephonic option. 95+% of the time, they preferred to just talk over the phone. But today we're going to go through a couple of specific patients to really tell the story of how this care team operated. Now, a few things regarding the co-occurrence, and we focused on depression here, depression and chronic disease. I don't think any of these literature citations are going to come as a big surprise to anyone, but depression is associated with risk factors for cardiometabolic chronic disease. Here we see obesity and hypertension. And as the number of chronic conditions increases, so does the likelihood of depression. Individuals with cardiovascular disease, they're more likely to develop depression, and conversely, with a history of depression, individuals are more likely to develop incident cardiovascular disease. So really the point here is a co-occurrence of cardiometabolic chronic conditions and behavioral health concerns makes chronic disease populations appropriate for deployment of this type of care team support, which helps navigate everything from social determinants of health to life stressors and crises. So here we see this co-occurrence holds true in Hawaii. And we just picked one example here. Looking at the Hawaii Health Data Warehouse shows us that Hawaii residents with diabetes, there's greater occurrence of depressive disorder. And the data was similar when we looked at obesity and history of cancer, once again, from the Hawaii Health Data Warehouse. Here, when we initiated the project, we reviewed the evidence, and once again, really with a focus on cardiometabolic chronic diseases. We saw a lot of great publications. This is one that we looked at, and as you can see from this meta-analysis compared to solo physician care, the team-based care it resulted in greater reductions in blood glucose, blood pressure, and lipid levels. As far as the composition of the care team, the care teams most often included nurses, and that could have been a registered nurse or a nurse practitioner or pharmacist. And interestingly, there are greater reductions in those metrics that we talked about were seen when the team included a pharmacist. But these weren't enormous care teams. They weren't 5-6 people. It was the patient, primary care physician, 1 or 2 additional team members. So we felt that was well suited for private practices because it's kind of hard to coordinate, 5 or 6 people in there. So what we did, we set forward to deploy a care team with a health coach coordinator. And that you may be like, what did he say? I've never heard of a health coach coordinator. We kind of made the title to reflect what we felt was appropriate here. We'd seen, in the literature that health coaches can be beneficial, and I know functional medicine uses them regularly. But a trained health coach that works with the patient on health coaching, but also supports care coordination, and a clinical pharmacist. And I think the obvious purpose for that clinical pharmacist would be medication management, which that's what the pharmacist did. But that pharmacist also worked as a close clinical partner with a health coach coordinator to support whole person care that, identifies and addresses the clinical and non-clinical drivers. So really that partnership was one of the keys. And, as we get into this, we'll get into a little more detail of what that looked like. So we are going to move on now to really some more details about this care team, and we're going to tell that through the specific case studies. So we have real patient stories here that experience this, and we've changed the name so there's no protected health information in here. And we also, we have case studies that are written up about this. We can share those with you if you'd like. We actually have the patients review those, attest that they're accurate, and agree that we can share them, and we have them sign off on those. So with that, Blair, I will turn it over to you, and you let me know when you want me to advance the slides for you.
Okay, wonderful. Well, as Carl said, we do have 2 patients that I'm going to review, and I want you all to kind of relate back to, in your memory of a patient that you've had like these. And we feel like we picked 2 that most likely everyone's had someone similar. They've all had a Leilani and a John at some point within their patients that they've seen. So first is Leilani. So Leilani is a female in her late 30s. She has a lot of stress on board. She's kind of had this ongoing divorce and joint custody of her children, which has been very messy for her. She lost her mother a few years ago, and it's just a very, very hard loss for her. And on top of that, being a caregiver for her father who is on dialysis. She's doing a lot of crisis work or crisis projects at work, really long hours, no time for her at all at the moment, and just getting a lot of these kind of funky rashes and allergies, chronic bronchitis. So she just really didn't even know where to start, how to even begin to look after herself with everything that she had on board. She's a patient who is just rushing from one task to the next, just on that hamster wheel, rushing from the morning to the evening, just to rush to get to bed, to wake up, to do it all over again. And she just didn't know how to stop, to take care of herself. And now at the end of the day, her health is really suffering because of this. As a result of her chronic stress and her current lifestyle, she has the following, chronic conditions. She has uncontrolled hypertension and chronic inflammation. And we know that, what is stress doing to our body? So stress signals the brain, which basically is telling our adrenal glands to release cortisol, which then activates our macrophages to release NF-kappa B, which is highly inflammatory. And that's really what's leading to a lot of these conditions that she's having. She's actually already seen 2 specialists, a rheumatologist and a psychologist, but she had just so much on her plate that she just really welcomed the support of a health coach and clinical pharmacist. And she also is a former athlete. So she really liked the idea of having like a health coach to support her. That's Leilani. Next slide, please. Okay, our next patient here is John. So he's a male. He's in his early 60s, and he is your typical older male patient who is just very pessimistic about life and health and everything around it. Unfortunately for him, a lot of his friends have passed away, and he pretty much was like, well, I'm going to have that similar fate too. Like I can't believe I'm still around, because everything he was doing is what his friends have been doing from a lifestyle perspective. When the health coach asked him, like, where do you see yourself in 10 years? He pretty much was like, dead. I can't even see myself in 10 years because I'm not going to be here. So he was even looking at like, where are you going to see yourself in 6 years? He saw himself as a frail individual, just being very dependent on other people. He had a lot of joint pain, very pessimistic about taking any medications and even healthcare in general. A big lack of purpose, unfortunately, ever since his retirement. I think his work really provided him with a sense of socialization and purpose. And since he's been retired, he just kind of sits at home and isn't really doing anything. And as a result, he has chronic conditions of uncontrolled hypertension and type 2 diabetes. Next slide, please. So this is our care team that we created. So as you can see, our patients are always going to be in the middle. We're always patient-centered when it comes to team-based care. And as Carl had said, what the literature showed is that the team basically consists of your primary care provider plus 1 to 2 additional team members. And that's exactly what we had. We landed on a health coach coordinator, which focuses more on the non-clinical aspects of health, and our clinical pharmacist, which is focusing more on our clinical aspects of health. Alrighty, so what's the overall goal of a care team? And I always like the saying that teamwork makes the dream work, because it does. And I think it's so hard, and I'm sure a lot of us know that working as a solo practitioner, it's so hard to be able to do everything we want to do and support a patient as best as we can. And that's why the team really makes such a valuable addition to supporting the patient on their health and wellness journey. Our patients are complex. Both clinical and non-clinical issues are coming up, and everyone is unique with their own sets of, needs and issues and things that are coming up. For all the providers on the call, how many of you feel like you have, adequate time to address all the clinical concerns that come up with your patient, right? I think that's a big thing. Like, how do we address all the clinical things in the limited amount of time we have with their patients? Nobody has enough time. Yes, exactly. And then, if we don't even have enough time to address the clinical needs, most likely we're really scraping the surface of all the non-clinical concerns that our patients have, which sometimes for a lot of our patients, those are more of the bigger issues at hand for them. You know, I think, and that's why a care team makes such a difference, that if we can't address the non-clinical aspects, how do we even begin to address, or how do we address all of it all together, right? And then when we work with an individual, with our patient, we go, oh, they're just non-compliant, right? And ideally, the team helps with that and helps to shift that mindset, because our patients all want to be compliant, but maybe it's us missing the mark on not being able to address really what is their concerns at that time. You know, I think, you know, we all know the importance of the non-clinical drivers of health, but the main question is who should be addressing all of these concerns of our patient? And at the end of the day, an effective team allows each member to get right into where they can add the most value. And, you know, I think overall, the patient expectation that we've kind of set up with the model that we have is that they have to go to these multiple providers and different community resources to really be able to get all the support that they need. And this is really shifting that model a bit of how do we decrease those barriers? Because we know a lot of times when we make referrals, that's a barrier within itself of someone actually even moving forward with that referral. How do we make it so that we can provide a lot of the support within even like a primary care setting? And that's, you know, what we're trying to address, and ultimately bringing down the barriers and having a care team, the people who are trained in very specific areas, can make a really big difference in the overall health outcomes. And together we are unstoppable. That is correct. So, you know, at the end of the day, we do need a full person approach to health and wellness. It really just doesn't work any other way. Yes, it can work, but to get, you know, the best outcomes, we really need a full person approach. You know, from a clinical aspect, as a provider myself, it is really hard with all the pharmaceutical drugs that are out there. There's just more and more drugs per class now. The formularies are always changing. There's always different ways in regard around, you know, how to make medication management cost effective. You know, it's, if we don't fully understand, but at the end of the day, we don't fully understand what are the patient needs, you know, is cost an issue for the patient? What are their social determinants of health? You know, and how do we bring that all together to create the best action plan for them? And that's really the biggest aspect of where we have this health coach who comes in and is able to really help and support somebody with the lifestyle modifications, addressing the social determinants of health. You know, it helps to then increase compliance in regards to, you know, is there a reason they're not taking their medication? Is it cost related? Is it because of transport? Is it health literacy? You know, the care team helps to address all of these aspects and provides the support the patient needs, and then can really improve health outcomes due to agreed upon compliance. It's interesting, we were recently meeting with the clinical pharmacist on this project that we did, and he had said that he's actually getting more referrals now to change patients' behavior around medications. So that tells me that providers are recognizing the importance of behavior change, but unfortunately just there's not enough time around there, you know, for them to be able to address that in an effective way. So that's why a clinical pharmacist with a health coach is that perfect duo to really accomplish this. And like I said, it's really adjusting our own provider mindset that a patient's not non-compliant. You know, it's having us and allowing the team around us to address what's going on so that we can support them so that they are able to walk that path of health and wellness. And it's hard, right? Because we know that open-ended questions is like opening a can of worms, especially if we only have 2 minutes left in a quick, you know, appointment that we have with somebody. So again, the team can really address all of those.
With that, I'll jump in and talk a little bit about the logistics of, you know, the project that we did. And also, I'm going to speak a little bit, and Blair will get into this a little further. I saw a comment on the medication management. And yes, that was the bar that met is comprehensive medication management. So actually, the pharmacist had a signed collaborative practice agreement, and they were able to adjust the meds under the physician's license. And they were able to do so by putting in the prescription order right in the EHR. Now, that collaborative practice agreement defined certain disease states. So in this case, it was for statins and antihypertensive agents. But where it was outside of that, they made recommendations. I think one thing that's really interesting to note with the pharmacist is, these are a couple of pharmacists that participated in this. Both of them are faculty at College of Pharmacy, Dr. Bryce Fukunaga and Dr. Jared Prudencio. And they have a strong background in teaching diabetes prevention programs and that sort of lifestyle guidance as well. So we found that to be incredibly useful in this as that clinical partner with the health coach, where the health coach could really get things started for the identify the patient's readiness to change and really start to work with them on some SMART goals and health coaching and care management type techniques. And then the pharmacist would be able to come in and really build upon that with disease education focus. One of the things that I think is interesting about that is, we talk about non-compliant patients, and I see William provided some great feedback who do not fully understand, especially with the case study, that we're going to get into a little more. We talked about John at the beginning. There was a lot of understanding there that we saw that the combination of the health coach and the pharmacist were able to impart. And for those that are interested, I don't know if the slide deck goes out after, but we're not going to get into the resource analysis, but I have in the additional slides at the bottom, there's the time per month that the pharmacist spent, that the health coach spent. And this wasn't them spending hours per month. As a matter of fact, coupled with the health coach, the pharmacist was able to spend just 9 to 10 minutes a month coming in to do a specific part. Now, you may say that sounds like what's even the point. That actually was once every 3 months. So really every visit was substantial in 20 to 30 minutes. But with that, 2 or 3 times a month, it really brought the average down. And we deployed this with remote patient monitoring, as you can see, a blood pressure cuff. And that really allowed for, data that typically isn't seen in the primary care setting to really help the care team navigate, what's going on with the patient, but also to help get the patient more engaged in their care. So to speak a little bit more to the logistics here, a letter goes out, patient's name is on that, comes from their practice. Although this care team was external, and here's our health coach coordinator, Joanne Marabella, and she, is an expert in bringing people along the path of identifying readiness to change and helping them make those effective changes. So letters went out where the physician introduced the concept and the care team, and a follow-up call is made to the patient that says, your doctor wants to offer you more support to focus on prevention and more support to, on other things that maybe we don't get to in the clinic that can really improve your health. So based on our experience and based on, we did patient feedback surveys, which are also in the additional slides, you can see those. Really, everything pointed to the patients having a great integrated care experience, very seamless, even though this care team was actually not an employed part of the practice. So with that, a slide that really represents what this journey looked like. And there's really a sequential aspect of this. So I was trying right before this to put an arrow in that took us around this way. Unsuccessful, but we'll see if we can get that in the future. But really, social needs and social determinants of health. And let's say the patient doesn't have any social needs. Well, even that connection that the health coach makes up front is really satisfying, I think, a social need that everyone would have if they're going to be working with someone on their health, is a rapport, a connection with someone. So we see that this moves, this way to curiosity, engagement, and health literacy. And we see this as a tipping point. And this is something we saw a lot in the Ornish program. And we saw it again here in this deployment of a care team, empowered to prioritize needs and health. And one thing that includes is having permission. Busy people with, kids, sometimes caregivers for older adults, and lots of responsibility for other people on their plate. Sometimes they don't feel like they have the permission to take care of themselves. That's not always the situation, but there's other situations we can say, but we see that there's typically a constant tipping point here where a patient realizes that and feels empowered to step up in their accountability and self-management. So with that, Blair, I'll hand it over to you to speak a little more to this slide and take the next few.
Wonderful. And I'd caveat that and just say that one of my favorite prescriptions to give to my patients is normally self-care. And they kind of laugh at me. I'm like, no, I'm serious. Like, self-care is so important. And I'm giving you the prescription to do this. So Carl really kind of explained a lot of this in regards to really addressing all of these different aspects of health, right? So it's a whole body approach and looking at all these different areas, and especially healthy habits. I know someone had said, like, what about stress management? And that's one of the big aspects, right? So the health coach can really dive into what does the individual need, and what makes sense for them, and how do I help to hold them accountable, right? Carl, can you go to the next slide, please?
There we go.
Now, the patient role, what's the responsibility of the patient? Now, this looks complicated and complex, and it is, because at the end of the day, each of our patients are unique. They have their own complexity and needs and concerns to address. There's always a lot to work on with our patients and to support them with. But when you have someone that's highly trained, such as a health coach, in this type of area to help empower somebody, it becomes this complexity just becomes clear. It becomes organized. It's made into these really tangible steps to move someone into that preparation, then action stage of change. And it makes a big difference on the outcomes and how a patient is feeling just supported without any one team member feeling overburdened. Because as someone had mentioned that, things are just dumped on the primary care provider. Well, we need a team to really support all of that. At the end of the day, the team is here to lay out the path of health and wellness. And then the health coach really just guides them along that path and provides them with like that first that listening ear to understand, what do they need? Then second, come up with their, help the individual and the patient come up with their own ideas and motivation of how they can get started. At the end of the day, the hardest thing is always getting started. But once things are in motion, things often stay in motion. And that's our biggest goal. Now, I'm going to use the two case studies to kind of talk through this slide and explain how we use the health coach and the clinical pharmacist together to create health outcomes. So as I had shared, the health coach first listens. She listened, I'm going to use Leilani first. So she really listened to Leilani with curiosity and empathy and understood Leilani's own personal challenges, concerns, and areas of stress. Then the health coach was able to identify what mattered to her the most and to be able to pull on these, what mattered most to her to help spark motivation. And for her, it was to manage stress, control blood pressure, lose weight, regain health, and just feel happy. The health coach helped to address her readiness to change and used strength-based coaching to help her make those achievable and realistic changes and goals. And then worked with her to make these little baby steps, make these small changes that she could fit into her schedule to help her find these mindful minutes in her day and figure out what made her feel relaxed. And for Leilani, she discovered it was listening to music. So encouraging those mindful moments of listening to music. And then the health coach would really help to identify small wins along the way, and measuring, when Leilani started to measure her blood pressure, she actually was able to see how her stress, how her eating, and these other things like her work, how it was really affecting her body from a physiological standpoint. And then, Joe was able to gather, or not Joe, sorry, she was our health coach. Our health coach was able to gather all of this information and then really share it with the pharmacist. So she, the health coach created this trusting relationship, which made the clinical pharmacist's job more enjoyable. He was able, the clinical pharmacist was able to just get into it right away and do what they do best, which is medication management and disease education. the clinical pharmacist had this wealth of information going into the visit, which made it really effective. The clinical pharmacist knew that that Leilani had a willingness to take medications, that the pharmacist knew what her concerns were, and allowed it to be a much more focused consultation. And then any clinical issues that came up along the way that the health coach found, they had a clinical partner within the clinical pharmacist, and obviously as well as the primary care provider, to be able to address those. And the health coach understands their own limitations. They're not fully clinical trained, and all health coaches are different, but our health coach in particular was not clinically trained. So any clinical questions that came up were addressed with the clinical pharmacist. And then our next patient, John. So actually, what I'll have you do, Carl, you can go to the next slide, and
Okay.
It'll kind of highlight some of these things as well. So John was our adult male in his early 60s. And, he just didn't really want to take responsibility for his own health initially, because fear was really stopping him. And that's something that the health coach was able to identify. He did not want to take his blood pressure readings because it was safer not knowing. Because if he saw the numbers, it reassured him that, yes, he is going to die soon. And he didn't, that was so scary for him. So at the end of the day, the health coach really listened, again, with that curiosity and empathy, and helped him to identify, that he actually really valued being independent. And the thought of him being dependent on others was not what he desired. And then the health coach also recognized that he wanted to be a role model for his daughter, who actually recently was diagnosed with hypertension. Again, the health coach helped to create SMART goals. So SMART goals are small, measurable, attainable, realistic, and timely goals. And for John, his focus, he didn't want to take medications. And he really was, after talking with Joe, motivated to make lifestyle changes. And that was his primary goal. So that was the main focus. The health coach was able to gather information, that John was your typical non-compliant medication guy. If his primary provider provided him with medication, he'd be like, okay, and then not take it. And his levels were definitely high enough that he needed it. But he just wasn't wanting to take the medication. And this was very valuable information for the clinical pharmacist to know. Can you advance to the next slide, please? If the clinical pharmacist went into the appointment and saying, here, John, your blood pressure is high, take this medication, instantly that trust would have been lost. And that everything that was, that could have been effective would just put a big wall up. So the clinical pharmacist knew that John wasn't interested in taking medications. So what he did was the clinical pharmacist focused on disease education and talked about what can be the consequences of long-term high blood pressure and what that could, the damage that could do, to make sure he was fully educated and help to bring up his health literacy. And he also did mention what the medication does to provide clarity and to increase knowledge. So in case John ever did decide to take medications, that he understood what they were doing for him. As he was scared, he thought they were going to damage his body more than help his body. And as we know, at the end of the day, John would be a perfect person who could really benefit from therapy, right? And he's probably a male that's never going to go to therapy. So this approach with a team really supported him and supported him in different ways and really helped him with his behavior change. He's a typical guy. The primary provider would make referrals and he just wouldn't go. But the fact that this team was a part of the primary care provider, it was convenient and it was easy for him. He figured, why not? I can get on a phone and talk to somebody. He was also quite lonely. So the fact of talking to somebody was really helpful for him.
And I'll jump in here for a little bit and talk about the feedback that we got from these patients. And as mentioned in the additional slides, we can see that there's feedback from other patients. We got open-ended feedback and Likert scale feedback. So that's definitely something that, looking at the slides, if you're interested to learn a little more. But, Leilani really appreciated this support, was very engaged in it, and appreciated the approach to small baby steps towards change. One of the favorite things that I saw in Leilani's feedback is after achieving some small wins, and H2C is our shorthand for health coach coordinator. We had first put HCC, but we know some people's mind goes to hierarchical care conditions, which can have a negative kind of connotation. So anyway, the H2C, she declared, "I love being happy." We thought, just to have that sort of support network that helps walk you through those life stressors, and keep a focus on what you want out of your life and your health. And so we really see that, the health coach coordinator, through her feedback, was integral to her health transformation, and she stated that. So these are all things that we heard from the patient on Leilani's side. John really appreciated the accountability that was created here. And, one thing that was really interesting about John is it took him a while. I mean, I think this is the perfect patient that without this external support, never would have effectively made changes. And we saw his blood pressure come under control after about 6 months, but it really 3 months, he was pre-contemplative. Yeah, he was not really ready. He was working through, I think, experiencing some hopelessness, right? And kind of a little bit lost. And so, the health coach coordinator, you can see, he expressed that he appreciated the health coach coordinator's patience with him. We can see that right here. And that was, I think, one of the keys. He needed that additional support to kind of get his head together and to overcome, some hopelessness that he was experiencing. And he went on to say that he felt the health coach coordinator and the care team support saved his life. He felt it was a wake-up call to really, make him take better care of himself and prioritize his health. So if we talk about, and I know there's these are wordy slides here, so they may be good to go back and look if you have an interest. But the health coach coordinator's perspective, the health coach coordinator really felt that they were an effective sounding board, and the health coach coordinator deployed a lot of skills in strength-based coaching, empathetic listening, motivational interviewing, all things that the folks on this call are aware to help patients along this journey towards their health goals. But the empathetic listening is probably one of the things that really rose to the top of making sure to take that time to hear from the patients. And that was consistent with both John and Leilani. And Blair, anything that you would add to this on the health coach coordinator perspective?
No, I mean, I think that's the main thing. And it's at the end of the day, it's just creating space for someone to talk. I mean, at the end of the day, everyone just wants to be heard. And the health coach really created that space for individuals to be heard. And they felt really, really supported within that aspect. And they really linked it back to the support of their primary care provider as well. So the health coach wasn't seen as a full different entity from the primary care office. It was seen as an integrated part of the primary care, and that actually increased their overall happiness and feeling supported by the care team and the primary care office as well.
And we are going to come to a wrap up where we can have questions. Just going to throw this out really quick. Team-based care components. And this is a busy, confusing slide, right? The whole point of this is to really say there's a lot to consider, right? And I know that that's not going to come as a shock to the people on the phone here. If I was to say the biggest thing that rises to the top is right here, funding and reimbursement. How does that work? And all of these are challenging problems, that included. So just really throwing this out here for us to appreciate how much goes in to getting a care team intervention like this, and how much needs to be thought about to really move towards a model that's generalizable, transferable to different environments, and that can be scaled and sustained. So with that, a little, just to let you know, we have documented case studies here that we can send you if you're more interested. As you've seen the link to the slides, there's a lot of additional slides. Just to let you know that this project was a collaboration. I mentioned the pharmacists that are faculty at Daniel K. Inouye College of Pharmacy. We worked with Dr. Amy Grace and the U Healthy Hawaii Initiative to help us coordinate these things. Was funded by the State of Hawaii Department of Health, their Chronic Disease Prevention and Health Promotion Division. So this is, work we continue to do. We're now expanding this, and we've been working with Queens now for, close to a year if we count the planning on, and the health coach coordinator has been deployed there since I think December of last year. So really new challenges and new opportunities there. So we're constantly working to look for new opportunities to deploy these type of team-based care models. As mentioned, lots of additional slides. I won't get into those at this point, but you can go look at them themselves, and we will open up this for questions. So I don't know, Summer, do we usually take questions out of the chat, or how's that?
You can do either way, but Dr. Bill Ware, he's in Guam. And so one question he asked early on was, how did you pay for the pharmacist, or how'd you find the pharmacist? I think he said.
Yes. So what we did was, the pharmacists were out of University of Hawaii faculty. So affiliation agreements. Yeah, they're in place with Queens and Hawaii Pacific Health, and medical schools have, and pharmacy schools have these affiliation agreements on the ready. We entered into them with the primary care practices. Resourcing is such a huge challenge here. Really hard to hire a pharmacist for, we like to call these demonstration projects. Yeah, really hard to hire a pharmacist to go, hey, we're going to do a year project, and we need you for 0.25 FTE. So all this is funded through, Department of Health. And I think, when you get to the funding, there's a lot of which came first, the chicken or the egg. We've seen a lot of fee-for-service codes that can be potentially billed incident to under general supervision. But it takes a lot to work that out. And until you have a model that works, you can spend a lot of time on that administrative. So the Department of Health has an interest in moving this forward. So it's provided funding to cover, these pharmacists' time, and working in the UH system to do so is one of the more effective ways that we've found to do this, to demonstrate. Then we can take it to payers and other funders to really say, hey, how can we plug this into part of the system with funding and reimbursement?
And so we do have a lot of pharmacists in Hawaii who are looking for work. So maybe we could recruit some to Guam.
Yeah.
Yeah. I like the combination. You had a health coach and a pharmacist. Do you think that's the ideal team? Because some people have social workers on the team, some people have community health workers. And how do we know? Well, okay, how am I going to ask this? Would it be different types of practices might need different teams?
Yes, I completely agree. And that's where I think the generalizable and transferable is such a challenge, right? It's almost like you can have a foundation, but you really need to be adaptable when you go into different practices, different health systems. To let you know, right now we're working on getting community health workers into this role to see if this is something that community health workers can do. So in Queens, that's the next step with our project there. The one thing that in the private practice world, I feel like worked really well is having a team with two members. Yeah, so not having too many team members. What we've seen with Queens that's really interesting is that because Queens Clinically Integrated Physician Network has all these great services, that the health coach coordinator really, they can have this longitudinal relationship and then really have a broader set of resources to refer to when there's things that are more along the lines of social services, because QCIPN has built all those out.
That's right,
But,
they do.
yeah, but Blair, I'd love for you to jump in and give your perspective on that as well.
In regards to who should be on the team.
Yeah, who should be on the team and how it might need to be adapted to different settings, or different primary care practices. Yeah.
Yeah, I mean, I think it's really looking at the demographic of the people that are going and to that primary care provider. What's the health literacy? Are a lot of them Medicaid? Are a lot of them Medicare? And looking at that, and that can a lot of times give you a better indication of what resources would be the most useful, as well as looking, who are those primary care providers referring to the most within their community resources, right? If there is a referral for almost every other patient to a very particular, community resource, why not bring that internally, right? And I think it'd be really looking at that, and I think it's the dynamic of the team, and we know that each practice has a different group of patients that are going to it, and that's where you can really tailor it to that individual practice. And at the end of the day, asking, the primary doctor does know their patients fairly well, right? So asking, what do we think is going to be the most useful, valuable resource as a part of the team to get the best health outcomes, as well as, what are the main pain points that the office team is feeling? I always think that's a really big one. Is it all the trying to do all the pharmacy stuff and prior authorizations or whatever that may be, right? So that's a lot of time for a team member of, maybe a medical assistant that could be spending their time elsewhere. So really having that open conversation with the office to see what is it that they need the most.
Do you guys think that you are sustainable? Have you developed a sustainable plan, or is it still in the works, or what do you think?
So I think that we have set a foundation, and now with working with Queens, that gets us into a more deeply resourced organization. I think it is impossible for us, and I think this speaks to, I'm reading through some of the questions too, where does Derigo come from? Derigo is Latin to guide, right? The foundation of the organization is going, we can get in there and support. We know that health systems, health plans, they're not staffing up for innovation, right? They're completely at capacity with the day-to-day. So getting people that have expertise in these areas to be able to come in and augment and support this planning for implementations. But, have we achieved sustainability, scalability? No. And we don't see that we can do that alone, right? That's moving into this relationship with Queens. We see them as being a key partner. We have relationships with the health plans, and we're constantly updating them. But as everyone can attest to on this call, I'm sure these are long strategic kind of plans, yeah. And we need to stay in our lane and continue to push on how care teams can potentially fix this. I'll speak to one other question that I think is related. How do you determine cost savings for improvements in patient health? That's another challenging one, and it's one that takes a long-term view, right? I can tell you with the work that I did with the Ornish program with HMSA, where we landed on that was a mixture of claims and clinical analysis, yeah, that included pharmaceutical claims, and it was matching based off of, so it's almost like trying to create a randomized controlled trial where you look out and you say, based on age, sex, and disease burden, match, and then follow through people that had similar underlying health conditions, age and sex, over a period of a year to 2 years, and see if participating in this led to a difference in costs. Pre-post is the way what a lot of people use, and it's subject to a lot of variability. And a lot of, there's a lot of studies out there that show 2 out of 3 of the people that are high cost this year will be low cost next year, no matter what happens. Yeah. And so with that, you really kind of have to have a large enough N. So they're definitely complex things. And, we are wanting to take our part in that journey, but we realize that we really need to be working collaboratively with a lot of different stakeholders that are much bigger than us to come to sustainability and scalability.
And then there's the CHC versus private practice setting.
Yeah.
And Kristen says her members feel supported with the wraparound services in one area in a community health center setting versus feeling a bit more isolated with private practice providers. And I would agree with that, because the private practice providers can't afford the wraparound services, although they would like probably to have it provided. And they've actually asked HMSA to help provide some of these services. Do you want to say anything about that?
I just agree. Yeah, the prospective payment system, I think, and the CHCs, I think are synonymous with the federally qualified health centers. So yeah, they typically are much more deeply resourced and with different licensures. So I agree.
So I am on a group with HMSA, Queens, CIPN, Hawaii Pacific Health, a couple private practice docs to look at administrative simplification. And I said, to HMSA's representative, it seems like it would be a win-win if you guys provided some of these wraparound services for private practices to share. And then you could have them check off a box for referred to wraparound services, and then you could pay them more if they use the wraparound services.
Yeah.
But anyway, I'm a dreamer. CHCs have healthcare managers also, right? I believe they do.
Yeah, and I definitely am not the expert at CHCs. I just know they're deeply resourced, and a lot of times they'll have programs that really help people through lifestyle change. So I would assume that they do have, these type of healthcare managers that may have a lot of overlap with what we're presenting as a health coach coordinator.
But they might not have the coaching aspect, which is needed. Let me ask you this. So one thing I think all practices say is, if the insurance company sends out a letter to my patient, the patient gets very confused about what they're supposed to do when, they want to know from the doctor. But if it sounds like in your case, the doctor sent out the letter and says, we want to offer you to work with Dorego, and here's what we can do. That sounds like the right partnership, and that their healthcare is under one umbrella, but that you are that part of the umbrella that is not in the office. I like the way that was done. I bet, I don't know, but I bet if it were just sent to them from Dorego, like a cold call, cold letter, it wouldn't have been as productive. So I think the partnership is really a nice factor there.
No, thanks. And I think that's great insight. I think too, it's the letter coupled with the message too. Your doctor wants to offer you more resources to focus on prevention. I mean, we saw anywhere from 33 to over 50% of people, because we decided to give them the choice, right? We weren't like, this is a standard of care, you're going to do this. But we saw, in that range, just to over 50% to 33% say, yes, yeah, I do want to, have more support. It's interesting that the wraparound services that you mentioned, I think that one of the big challenges with that is, and I'll give a specific example, is all the data flowing back to check the right boxes for clinical quality, right? So I'll give you an example on medication therapy management that I experienced when supporting the Comprehensive Primary Care Plus practices here in Hawaii. Comprehensive Primary Care Plus, the CPC Plus program, they rolled out, doing medication management post-discharge. Yeah. health plans also have a requirement to do that. So when the practices would do it,
Mhm.
the data wouldn't flow back, right? So the practices would do it post-discharge, and then 3 weeks later, the patient would get a call from the health plan to check that box, that medication therapy management box
Right.
that's required as a compliance thing.
Mhm.
You know,
It's a
that's
mess, yeah.
that's one of where and the patient would get confused. I mean, I heard this from doctors, like, we're doing this, and then the health plan is following up with them, but the data is not flowing back to get in the, STARS measures that they have to meet for Medicare Advantage populations have an enormous impact
Right.
on their cash flow, right? So yeah, that's one of the interesting things that just requires a lot of thoughtful approach, let's say. Huh?
Yeah. So we need more coordination at all levels.
Yeah.
So this was really helpful.